Very good evening, guys. We are here for the INICET test and discussion session of pediatrics. This is Dr. Chandhini here. So now let's start with the first question. How was the exam? I hope it was quite easy because most of the questions were from the topics which we have already discussed in the INICET hackathon. So now let's see the first question. Which of the following is not a criteria for severe acute malnutrition? Is it edema? Is it mid upper arm circumference less than 11.5 centimeters? Weight for height less than -3? Weight for age less than -3 standard deviation. So which is the right answer here? Which among the following is not a criteria for acute severe malnutrition? So the answer here is D. So what is the criteria for SAM? So criteria for severe acute malnutrition is we have 3 criteria. The first one is weight for height. So it is weight for height less than -3 standard deviation. It is not weight for age. So please remember it is weight for height and not weight for age. The second criteria is presence of bipedal edema. Presence of bipedal edema. The third criteria is mid-arm circumference less than 11.5 centimeters. So this 115 millimeters, nothing but 11.5 centimeters. So these 3 are the criteria for severe acute malnutrition. The one exception here is this is only for 6 months to 5 years. Okay. This mid-upper arm circumference criteria is not applicable for infants less than 6 months. So it is not applicable for infants less than 6 months. Okay. So now coming to the next question. True about the tape given in image. True about the tape given in image. Sorry. First option, it is Shelter's tape. Second option, used to assess mid-arm circumference. Third option, reading of 13.5 to 14.5 is considered undernourished. And fourth option, useful for frontline field workers. So it is a multiple answer question. So what is the answer here? Name a Shelter's tape. Is it so? No, this is called as Shucky's tape. It's called as Shucky's tape. It is used to assess mid-arm circumference. Yes, it is true. Reading of 13.5 to 14.5 is considered undernourished. No. Less than 11.5 is considered SAM. Okay. The fourth one, useful for frontline field workers. Yes. So what is this tape? This is called as Shucky's tape. So what is the use of Shucky's tape? To measure the mid-arm circumference. So as you see, it is a color-coded tape. So what are the colors there? 3 colors are there, right? One is the red one, the next is the yellow, and next is the green. So just like your traffic signal. So green means it is normal. So when the mid-arm circumference is more than 13.5 centimeters, it is normal. Okay. So where in yellow zone, if it is between this 11.5 to 12.5 centimeters, it is moderate malnutrition. Okay. The red zone less than 11.5 centimeter is severe malnutrition. Okay, clear? So this is used by the frontline workers, the Anganwadi workers, and the those in the primary health centers to assess mid-arm circumference and malnutrition. So clear with this? So the answer here is 2 and 4 are true. So the option that is right is C. Now coming to the third question. So what is this instrument? Any idea what is the name of this instrument? What is the name of this instrument? This is called as hair pendant caliper. This is called as hair pendant caliper. So what is the use of this hair pendant caliper? It is used to measure the skin fold thickness. Okay. So the right answer here is B. It is used to measure the skin fold thickness. So where do you measure skin fold thickness? In the triceps. So skin fold thickness is measured in the triceps. Okay. Fine. Now coming to the fourth question. Identify the false statement. So we have given 4 statements. You have to identify which one is not true. A. Child reaches half of adult age by 2 years. Right or wrong? Yes, it is right. The child reaches the half of adult height by 2 years of age. Infantometer is used to measure length in children less than 2 years. Yes, infantometer is used for measuring length in less than 2 years. Child increases length by 12.5 centimeter in the first year. No, that is the wrong statement. Last option, stadiometer is used to measure the standing height of the child. Yes, so this is right. Now coming to this height. So what are the instruments or equipments that you need to measure height? So we all know these two things, right? The first one is called as the infantometer. This is called as the infantometer. Okay, so this is used for measuring what? Length. You call it as length in children less than 2 years. Okay. It is not called as height, it is called as length. Whereas this one, the next image is called as the stadiometer. This one you would have seen in all the schools and all. No, this is how they measure the height of the child. So this is used for measuring height in more than 2 years. Okay, the standing height is measured using stadiometer. The length is measured using infantometer. Okay, now coming to the normal height. Okay, normal length and height. What is the normal length of the newborn? Any idea? What is the normal length of the newborn? At birth, the normal length is around 50 centimeters. Okay. So what happens? Yes, right. It is 50 centimeters. At 1 year of age, it is increased to 75 centimeters. So how much is the increase? It is plus 25 centimeters. It is not 12.5. It is 25 centimeters in the first year. Now coming to the next one. 2 years, what happens? So there is an increase in 12.5 centimeter in the second year. So it becomes somewhere around 87.5 centimeters in the second year. And then after that, the formula is called as Veitch formula. We use a formula called as Veitch formula. What is the formula? It is 6x plus 77. X is age in years. Okay, so 6 into age in years plus 77 is used to calculate the height for children to 12 years of age. So this is the normal length or height. So you can see now the first year the increase is 85 plus 25 centimeters and it is not 12.5 centimeters. Okay. So the option answer here is C. Now, coming to the next question. Child transfers object from one hand to another. What does it imply? Is it ability to compare object? Is it ability to handle small objects? C, visuomotor coordination, or D, voluntary release? So there, a developmental milestone has been given to you and they're asking you the implication of that milestone. So when a child is transferring object from one hand to another, what is the child doing? The child is trying to compare objects. So it is ability to compare objects. This is the right answer. Now let us see what are the few milestones and their developmental implications. Okay. Now, reaches for objects. When does a child reach for objects? Yes, by 4 months of age, the child will start reaching for object. So it means visuomotor coordination. The child is able to see something and the child is trying to reach for it. So there is visuomotor coordination. Next, palmar grasp, gone. So what is palmar grasp? Palmar grasp is a neonatal reflex. When you keep something on the ulnar aspect of the baby, what will happen? The baby will try to hold it. You've seen newborn babies, right? Most of us will have photos of the newborn babies holding our fingers. This is because of a reflex called as palmar grasp. So this palmar grasp is a neonatal reflex which disappears after some time. That is, when will it disappear? Yes, around 4 months, when the child is trying to reach for an object, this palmar grasp should go. So what is the implication? The implication is voluntary release. So when this grasp is gone, the baby is voluntarily releasing the object. Okay. So implication for palmar grasp is voluntary release. Next, transfers object and to pan. Just now we saw it is comparison of object. The baby is comparing the object in both the hands. Next, thumb finger grasp. This is nothing but the pincer grasp. Ability to explore small objects. So using the thumb and the finger, the baby is trying to explore small objects. Stares at own hand. What is this called as? A baby staring at the old hand is called as hand regard. This is called as hand regard. So that means the child has discovered the baby is having hands. Till then, the baby doesn't know that it has hands. Suddenly, at 4 months of age, the child knows that, oh, I'm having hands, 2 hands. And then the child is looking at his own hand. So it is self-discovering his own hand. Okay. Now, bangs tube cubes. If you have seen small children banging two objects, right? So what are they doing? Active comparison of objects. The next one is uncovers toy. What is uncovering toy? You keep something, you hide it, the child will try to cover it. I mean, it will try to take it out. So that is called as object permanence. Okay, fine. So these are the milestones and developmental implications. Now let's go on to the next question. Match the following. So you have to match the milestones. Social smile, which age? Social smile. It is 2 months. Waves bye-bye. When does a baby wave bye-bye? By 9 months. Sits with support. Sits with support at 6 months. SSS. Sits with support at 6 months. Bidextrous reach. What is bidextrous reach? Reaching the object with both the hands. That is called as bidextrous reach by 4 months. Okay. So this match the following. You have seen so many milestones. Now we'll just revise all the milestones that we know of. So what are the 4 main domains? What are the 4 main domains of development? First one is gross motor. Okay. So coming to gross motor. What are the gross motor milestones? The first, the baby will start gaining what? Neck control. So by 3 months, neck control. So after neck control, what will happen? The baby will roll over. So by 5 months, rolling over. Then 6 months, you all know, sits with support. Yes. Sits with support at 6 months of age. And then by 8 months, sits without support. Sits without support. Then by 10 months, the baby will stand with support. So after standing with support, the baby will try to stand without support and walk. 12 to 13 months, the baby will walk. By 18 months, the baby will run. And by 2 years, the baby can climb upstairs. How? 2 feet per step. Okay, climb stairs 2 feet per step. 2 feet per step. Then by 3 years, the baby will climb upstairs, alternate feet. Will keep 1 feet and then the other feet and then the other feet. So alternate feet per step upwards. What? Upwards. Climbs upwards. By 4 years, it will climb downwards. Alternate feet per step downwards. And by 5 years, baby can skip. Okay. So these are the gross motor milestones which you should know. One more thing you should remember is this riding tricycle. So when does a baby ride tricycle? Tricycle 3 years. Try 3. Okay. That one thing you have to know. And you should know the difference between crawling and creeping. What is crawling? What is creeping? Are they synonymous? Can we use the term synonymously? No. Crawling is what? Crawling is abdomen is on the ground. Abdomen will be on the ground and the baby is trying to move. That is called as crawling. Remember, commandos crawl. So what do commandos do? They crawl. Okay. So crawling is around 8 months of age. Creeping. What is creeping? Abdomen off the ground. Creeping is abdomen off the ground. Abdomen will not touch the ground. So creeping is somewhere around 10 months. The next milestone you should know is cruising. What is cruising? Cruising is the baby will hold on to the furnitures and try to walk with support. That is called as cruising. Somewhere around 11 months, the child will start cruising. So these are the major gross motor milestones that you should be thorough. Okay. Now next is the fine motor milestones. We'll go with the fine motor milestones. So fine motor milestones, it starts with bidextrous reach at, just now we saw 4 months. Unidextrous reach at 6 months. And then the baby will have something called as immature pincer grasp. Immature is baby is trying to hold the object with the radial aspect and the fingers. This is called as immature pincer grasp. Okay. So it is called as immature pincer grasp. Immature pincer. When is immature pincer? Around 8 to 9 months of age is immature pincer. Then is the mature pincer grasp. What is mature pincer? Like holding a pencil or pen like this. Just using your thumb and the index finger is called as the mature pincer. By 12 months, the baby will have mature pincer. And then coming to the drawing thing. The first thing the baby will do is scribble. When will it scribble? By 1.5 years, 15 months to 18 months, the child will start scribbling. And then what is the next thing a child would do? We'll put a vertical stroke. When? Vertical stroke by 2 years. Then we'll try to draw a circle. When? Circle at 3 years. Okay. So circle at 3 years. Then what is the child trying to do? After circle, we'll put a cross. By 4 years, the child will try to put a cross. And then what is happening? We'll try to draw a rectangle. 4.5 years, it is rectangle. And then triangle by 5 years. So this you should know. Can you see this resembles somewhat like a scarecrow? So this you should. These are the fine motor milestones. So gross motor, fine motor over. The next thing we are going to do is social milestones. Okay. Some important social milestones we will see. What is the first milestone? First milestone a child achieves to social smile. Yes. 2 months, social smile. So see, of all the milestones, the first thing a baby does in its life is social smile. But then what we do, as we grow older, we just forget to smile when we see people, right? So social smile is very important because that is the first thing that we are achieving, the first milestone that we are achieving. So 2 months, social smile. 3 months, recognizes mother. Then 6 months, stranger anxiety. So on seeing strangers, the baby will cry. So around 6 months, stranger anxiety. 9 months, waves bye-bye, says bye-bye. Okay. By 1 year, so play small, simple games, plays ball games and all. Okay. Then 1.5 years, what the child will do? Imitate household talks. Imitate household tasks. Like sweeping and all. No, if the mother is sweeping, the child will also try to imitate that. Okay. So this is important. These are some of the important social milestones. Okay. Then coming to the language milestones. Language milestones, important alone, we will see. Around 3 months, 2 to 3 months, the child will start cooing. Cooing. It will make cooing noises. And 4 months, it is laughing out loud. Laughs out loud. Okay. By 6 months, 6 to 9 months, the child will start speaking bisyllables. Okay, sorry, monosyllables. By 9 months, bisyllables. Like mama, dada, bisyllables. And then by 1 year, what will happen? 1 or 2 words the child can speak. Okay, 2 to 3 words. And then by 2 years, it will start speaking sentences, few sentences like come here, go there, like that. 1 or 2 word sentences the child can speak. By 3 years, the child knows its name, knows its gender, then can say rhymes. Knows name, knows gender, can say rhymes. 4 years, the child can say stories. Okay. So able to remember, these are some of the important milestones that you should definitely know before going to the exam. Okay. Fine. We'll move on to the next question. Object permanence is achieved by, what is the answer? What is the answer? Object permanence is achieved by, okay, it is 9 months. Okay, what do you mean by object permanence? Object permanence means a child knows that even after hiding an object, that object is still present. Okay. So if you're taking a toy from the child and hiding it somewhere, so child knows that it is still present and it will start searching for that toy. That is called as object permanence, or it is also known as constancy. Constancy, also known as peekaboo. We play peekaboo, right, with a child. So all this is object permanence around 9 months of age. Right? Other milestones which you should know is handedness. When does a child establish handedness? Whether it's right-handed or left-handed, when will you know? Only at 3 years of age, not before that. Only at 3 years of age, you will know what handedness is. Okay. And what is razzing? Razzing is blowing raspberries, like the blowing raspberries. That is around 5 months. Okay, clear? So major milestones we have covered. Let's move on to the next question. True statement about FIPV vaccine is. Full form of FIPV is fractionated dose of injectable polio vaccine. Is it true? No, it's not right. What is the full form? It is fractionated dose of injectable polio vaccine. It's not injectable polio vaccine. It is inactivated. Okay. So fractional inactivated polio vaccine. IPV is not injectable polio vaccine. It is inactivated polio vaccine. Please remember. Okay. Route of administration is intradermal. Yes, right. Schedule is 6 and 10 weeks. No. It is being changed recently. So the recent, since January 2023, the schedule is 6 weeks, 10 weeks, and you have one more dose at 10 months. You give one more dose at 10 months of age. So you remember this. Dose is 0.5 ml. No, it is wrong. What is the dose? 0.1 ml. That is why it is called as fractional dose of IPV. So what is the difference between this normal IPV and FIPV? Normal IPV, you give 0.5 ml. Whereas FIPV, you give a fraction of that. That is 0.1 ml. Normal IPV, the route of administration is intramuscular. Okay. Whereas FIPV, the route of administration is intradermal. And the third point, the schedule. Normal IPV, the schedule is 6, 10, and 14 weeks. Whereas in FIPV, the schedule is 6 weeks, 10 weeks, and 10 months. Okay, this 10 months, please don't forget, that is a recent change in the schedule. Okay, this is according to what? National Immunization Schedule. Okay, this is according to National Immunization Schedule. National Immunization Schedule is very important. You should know up to date. Okay. So national schedule is what we give in the government sector. So what is that we give at birth? What is given at birth? BCG, OPV, hepatitis B. Okay. So at birth, BCG, OPV, and hepatitis B. Next, we have 6 weeks, 10 weeks, 14 weeks. Okay. 6 weeks, 10 weeks, and 14 weeks. So what are the things we are giving at 6 weeks? Pentavalent. First dose. So what is pentavalent? Any idea? What is pentavalent? Penta means 5, right? So what are the 5 things in pentavalent? DPT, diphtheria, pertussis, tetanus, H influenza B, hepatitis B. So this was a previous INI question. What are the components of pentavalent? DPT, H influenza B, hepatitis B. Okay. Now, pentavalent first dose you give, and then you give, yes, FIPV, and then OPV, Rota, and then one more thing, PCV. Okay, clear? Now, 10 weeks, 6 and 14 weeks, they are the same. Okay, it is almost the same. So you give Penta, FIPV, OPV, Rota, and PCV in 14 weeks also. Then what is the difference for 10 weeks? 10 weeks, one difference is you do not have FIPV and PCV. So you have only Penta, OPV, Rota. Okay. So penta, OPV, and rota is there, but FIPV and PCV will not be in 10 weeks. So this you have to know. The next thing. After this, you will give a 10 months. What are the things that we are giving at 10 months? MR first dose. MR is measles rubella. MR is measles rubella. Then JE first dose in certain districts, not in all districts, only in endemic districts. And then now we are also giving PCV booster and FIPV third dose. Okay. So FIPV is given in 10 months. After this, you will give something in 18 months. 18 to 24 months, you will give something. What are they? DPT booster, all second doses. MR second dose, JE second dose, and OPV booster. Okay. So this is about 18 months. After 18 months, 5 years you give. What are the things that given at 5 years? DPT booster is given at 5 years. After that, 10 years and 16 years. That's all. So 10 and 16 years, what are we giving? We are giving TD. If it's not TT, it is TD. Okay. So this schedule, you have to be. Okay. Next one. Recent advances. What is Incovac? Incovac is the intranasal COVID vaccine. Intranasal COVID vaccine that is indigenously produced by India. So it is approved for use in children adults more than 18 years of age. What are the COVID vaccines that is approved for use in children? We have two vaccines, Covaxin and Corbevax. These two are approved for use in children more than 12 years of age. It is been approved for 5 to 11 years, but then we are not still started administering. As of now, more than 12 years of age, these two vaccines are being administered in India. So this is about Incovac. The next recent advance is Cervavac. So what is this vaccine for? For which disease? Cervavac. Any idea? Cervavac is for? To prevent HPV, human papilloma virus. Okay. What is the problem with this HPV virus? It causes cervical cancer in women. Okay. So to prevent HPV, India has indigenously produced Cervavac. It is quadrivalent vaccine. Quadrivalent vaccine. So what are the strains there? 6, 11, 16, 18. So HPV, 4 strains, 6, 11, 16, 18. Okay. Fine. Next question. All the following statements regarding vaccination of babies born to HIV positive mother are true except. So what is the wrong thing? What is the false thing about vaccination of babies born to HIV mother? Asymptomatic babies can be given BCG vaccine. Is it true or wrong? Yes, it is true. You can give vaccine to asymptomatic babies. MMR vaccine can be given to symptomatic babies with CD4 count more than 15%. That is also true. BCG vaccine should not be given to symptomatic babies. Yes, that is also true. OPV can be given to asymptomatic babies. Yes or no? No, OPV cannot be given even if the baby is asymptomatic. So now let's see some vaccination in special situations. Babies born to HIV positive mother. Okay, you will divide them into asymptomatic and symptomatic. Asymptomatic and symptomatic. Okay. Killed vaccines are not contraindicated. What about live vaccines? So we will discuss about 3 vaccines which we are going to give for this baby. The first vaccine is BCG. Can we give BCG to asymptomatic baby? Yes, you can give. Symptomatic baby? No, you cannot give. So first vaccine BCG is over. The next thing what we are going to see is MMR and varicella. MMR, varicella both are live vaccines. Can you give an asymptomatic? Yes, both MMR and varicella can be given in asymptomatic. What about symptomatic babies? Both can be given if the CD4 count is more than 15% in symptomatic babies. Okay. The next vaccine you're going to see is OPV. You all know oral polio vaccine is a live vaccine. Can we give OPV? No. Even if it is asymptomatic, you're not supposed to give OPV here. Okay, so instead what we can give? We can give FIPV or IPV here. Okay. So OPV, both symptomatic and asymptomatic, you're not supposed to give. So here, option D is the answer. So other special situations, tell me, corticosteroid therapy, can we give or not? When can we give? When we should not give. Okay. Suppose if the child is taking steroid more than 2 milligram per kg per day or more than 20 milligram per day for more than 2 weeks, then you cannot give 2 to 2, remember. Give vaccine. What vaccine? Live vaccine. You cannot give live vaccine. Then when to give? After stopping a drug for 1 month. There's an interval for 1 month and then you give live vaccine. Okay. Next, IVIG. IVIG, where do you give? For Kawasaki disease. There are so many diseases where you give IVIG. In case of Kawasaki disease, after a period of 11 months only, you give live vaccines. Okay. That is for Kawasaki IVIG. Cancer chemotherapy. The interval period is 6 months. Okay. There's one vaccine that you can give during chemotherapy, that is influenza. All other vaccines are contraindicated during cancer chemotherapy. Next, splenectomy. So what to do in splenectomy? So when a patient undergoes splenectomy, they are at risk of certain infections. What infections? Infections due to encapsulated organisms. Encapsulated organisms. So you should give 4 vaccines here. One is pneumococcal, meningococcal, H influenza, and typhoid. These 4 vaccines are to be given to any child who is undergoing splenectomy. When to give? If it is a planned splenectomy. Planned splenectomy means before 2 weeks. Okay, before 2 weeks you give prior to the procedure. If it's an emergency splenectomy, what to do? You give the vaccine after 2 weeks. You give the vaccine after 2 weeks. So this interval is also important. Now, what about preterm babies? Can we give or not? Yes. What are the vaccines we give at birth? BCG, OPV, and Hep B, right? You can give BCG and OPV irrespective of the birth weight of the baby. Suppose if the baby is less than 2 kg, you're not supposed to give hepatitis B. Then what to do? You wait for 1 month or for the baby to become more than 2 kg. Whichever is earlier, you administer. So less than 2 kg, don't give hepatitis B for preterm babies. One more scenario. Born to HPS AG positive mother. Mother is HPS AG positive. What to do? Okay, now what we do is, we will divide the baby into term or preterm. If it's a term baby or preterm baby. Okay. What about term babies? You give hepatitis B vaccine plus what? Immunoglobulin. Hepatitis B immunoglobulin. Vaccine as well as immunoglobulin has to be given when within 12 hours of birth. Within 12 hours of birth you give, and then you continue with the usual dosages. What are the usual dosages? Plus 2 doses, right? You give. Along with your penta you're giving, like that you give your original dosages. Whereas for preterm babies, even if it is less than 2 kg, you will give both vaccine, hepatitis B vaccine plus immunoglobulin. Plus you give 3 doses. So you don't consider this birth dose and you give another dose. So plus 3 doses you give in preterm. That is the difference between term and preterm here. Okay. Now vaccination special situations is over. Now we'll go to the next question. Good prognostic factor for ALL, acute lymphoblastic leukemia, among the following is hypodiploidy, age less than 1 year, leukocyte count less than 50,000, B, cytogenetics 814. What is the right answer here? Which has good prognosis? It is option C. Okay, option C is the right answer. So coming to ALL, what is ALL? Acute lymphoblastic leukemia. Okay. Lymphoblastic leukemia is ALL. Okay. Now tell me, what is the most common cause of cancer in children? Most common cancer in children. Most common cancer, malignancy in children. Most common malignancy in children is leukemias. Leukemias are most common malignancies. Among leukemias, the most common leukemia is Most common leukemia is ALL. Okay. So after leukemia, what is the most common malignancy in children? Other than leukemia, it is brain tumor. So the first thing is leukemia, then comes brain tumor. Among leukemia, the most common leukemia is ALL. Okay. Now coming to ALL. So how will you diagnose ALL? If the bone marrow shows more than 25% blast cells, it is diagnostic of ALL. Okay. So you have three types of ALL here. Okay. Pre-B cell, pre-T cell, and mature B cell. So this is around 95%. This is around 4%, and this mature B cell is 1 to 2%. Most common is your pre-B cell ALL. Okay. Now, if you see, the prognostic factors of ALL is very important. Now, let's see the poor prognosis. All others are good prognosis. So, poor prognosis. The first thing, what about the age? What about the age? So, age less than 1 year or more than 10 years carry poor prognosis. Less than 1 year, more than 10 years. So, what about the good prognosis? In between is your good prognosis. In between is your good prognosis. Your 2 to 9 years carries better prognosis. Now, gender. Male gender carries poor prognosis. Female gender carries good prognosis. Then, diploidy, based on the diploidy. Okay. So, in diploidy, poor prognosis is hypodiploidy. Hypodiploidy is poor prognosis. Hyperdiploidy carries good prognosis. It is just the opposite. Okay. Now, coming to the features. If the child has these 4 features, then it carries poor prognosis. One is the hepatosplenomegaly. The next one is the lymph node enlargement. Third one is the mediastinal mass. Fourth one is the CNS involvement, central nervous system involvement. If a child has all these 4 features, it has poor prognosis. In good prognosis, the child will not have these features. Okay. About the type. What about the type? Mature B cell has poor prognosis. All other types have good prognosis, but mature B cell has poor prognosis. The last thing is the cytogenetics. What about the cytogenetics? What about the cytogenetics? So if it is translocation 814, location 922, Philadelphia chromosome, and translocation 411, it carries poor prognosis. 814, 922, 411 carries poor prognosis. Good prognosis is trisomy 4 and 10. Trisomy 4 and 10 as good prognosis. So if you just remember poor prognosis, that is enough. Okay. So this is about ALL, prognostic factors of ALL. Now going to the next question. Which type of AML is associated with gum hypertrophy? So what is AML? Acute myeloblastic leukemia is AML. So in AML, we have 8 types. This classification is called as FAB classification, French American British classification. Okay. So according to FAB classification, M0 is minimal differentiation. M1 is myeloblastic with no maturation. M2 is myeloblastic with maturation. M3 is promyelocytic. M3 is associated with what? M3 is associated with what? DIC, disseminated intravascular coagulation. M3 is associated with DIC. M4, myelomonocytic, is associated with gum hypertrophy. Gum hypertrophy. M5 is monocytic, 6 is erythroleukia, and 7 is megakaryocytic. So this you should know. So gum hypertrophy is M4, which is myelomonocytic. So what is the answer here? A. Myelomonocytic is the answer here. Okay. Now, general aspects of AML. What are the characteristic findings you see in AML? Something called as rods you see in bone marrow. And then Characteristic finding called as chloromas. What are chloromas? Chloromas are accumulation of these myeloblastic cells in the skin, in the bone, especially orbit, spinal cord, all these areas, these accumulation of cells go and deposit. That is called as chloroma. Okay, these are the characteristic features of AML. Okay, chloroma and air rods. Clear? Now move on to the next question. Regarding CMV, cytomegalovirus, which of the following is true? CMV is the most common cause of non-syndromic sensory neural hearing loss in children. True or false? Yes, it is true. 30 to 40% are symptomatic at birth. No. Only 10% are symptomatic at birth. Diagnosis by urine specimen after 4 weeks. No, you should do it within 2 weeks. Developing countries, major cause is primary infection. No, the major cause is reactivation. So this congenital CMV infection is very important. Cytomegalovirus infection is very important. It is one among the torch infection, right? So coming to the causes of sensory neural hearing loss in children. If you see, 50% of the causes are due to this torch infection. Most common is because of torch infection. The others are due to syndromes. So now they have told it is a non-syndromic. So this is the leading cause of non-syndromic hearing loss in children. Clear? Fine. Coming to cytomegalovirus. So how is this infection happening? So either it can be a primary infection or it can be a reactivation of latent infection. So if it's going to be a primary infection. Primary infection means the mother is pregnant. During pregnancy, the mother is having infection for the first time. So what is happening here? The risk of transmission. What is the risk of transmission? Is 30% if it's a primary infection. If the mother is having CMV for the first time during pregnancy, the risk of transmission to the fetus is 30%. How many of these fetus will be symptomatic? Only 10% will be symptomatic. Okay. Only 10% of the babies will be symptomatic. Okay. Now coming to the next thing. Reactivation of latent infection. In reactivation, the risk of transmission is what? Is only 10%. Whereas symptomatic, only 5% will be symptomatic. So this you should know. Though primary infection, the risk is more. The most common thing that is going to affect the mother is what? Reactivation. It is not primary infection. Reactivation is more common than primary infection. Clear? So reactivation is a major cause of CMV infection in mother. Okay? Not primary infection. This you should know. Now symptomatic, you know, 10% of the babies will be symptomatic at birth. So what are the features of CMV? This can result in preterm baby, low birth weight baby. The baby can present to you with hepatosplenomegaly, sensory neural hearing loss, and what else? Jaundice. And one more thing, characteristic finding. What is the characteristic finding of CMV? Characteristic finding of CMV is periventricular calcifications. What? Periventricular calcifications. Periventricular. I'll show you the image. Okay. So can you see here? So this is the ventricle, right? Can you see calcifications here? This white spot. These are calcification. Where is the location? Around the ventricle. So that is why it is called as periventricular calcification, which is characteristic of cytomegalovirus. Do not forget. Now see this other image. Here also you can see this white spot, but it is not characteristically present in a particular zone. It is diffuse. It's throughout the cortex. It is throughout the brain parenchyma. So what is this? What is this? Which infection you have this type of calcification? Another torch infection. It is toxoplasmosis. Toxoplasmosis. Okay. Toxoplasmosis also has intracranial calcification, but it is diffuse calcification. Okay. What are the other features you can see in toxoplasmosis? Hydrocephalus, chorioretinitis. Don't forget hydrocephalus, chorioretinitis. chorioretinitis. Okay. So toxoplasmosis closest differential diagnosis of CMV in case of intracranial calcifications. Okay. Now continuing CMV. So how to diagnose CMV? How will you diagnose CMV? The most sensitive indicator of CMV is you take urine sample, urine specimen from the baby and look for PCR. You do PCR. Ideally, you have to do within 2 weeks after birth. Why not later? What happens if you do it after 2 weeks or 4 weeks? This can mimic a postnatal transmission also. We don't know whether it is during intrapartum or it is after the delivery the baby has acquired CMV. So before 2 weeks, if you do only, we can say for sure this is the transmission. This is congenital infection. So urine PCR by 2 weeks of age. What is the treatment you can give? Ganicyclovir. Ganicyclovir is given as treatment. So CMV is important. CMV is almost every year you get a repeat question from CMV. Clear? Let's go on to the next question. Which among the following vaccine can be used with respect to vaccine vial monitor? This is very easy. Can you see? In one, you can see there is one square, right, and a circle. So you have outer circle and inside you have a square in all the images. This is called as what? Vaccine vial monitor. So vaccine vial monitor is made up of a heat sensitive material. This material is heat sensitive, which changes color on exposure to heat. So this indicates what? VVM indicates what? Whether the vaccine has been stored properly in cold chain or not. Okay. So it is used to say whether the vaccine has been maintained in cold chain or not. So that is the use of this VVM. So you have 4 stages in VVM. The first stage is, can you see? In the first stage, this inner square, no, it is lighter in color than the outer circle. Okay. In second stage, the inner square is changing color, but it's still lighter than the circle. The third one, both the circle as well as the square is same in color. Whereas in the fourth one, the square is darker than the circle. So here, if you see, you can use the vaccine only if the inner square is lighter than the circle. Remember this. Whenever this inner square is lighter in color than the circle, you can use. You cannot use if it is same color or darker. So now tell me the answer. Where all when can we use? First one can we use? Yes, you can use. Second one can we use? Yes, you can use. 3 and 4, you cannot use. So when square is lighter than the circle, you use. So 1 and 2 vaccine alone, you can use. This is vaccine vial monitor. Okay. Next question. The vitamin deficiency that can lead to neonatal seizures. It's a direct question. The answer is pyridoxine. Answer is pyridoxine. Now coming to neonatal seizures. Neonatal seizures. What are the types of neonatal seizures? We have subtle seizures, tonic, clonic, myoclonic. Subtle, tonic, clonic, myoclonic. In this subtle seizure is the most common type. So they will not have all these tonic, clonic movements and all in subtle. Subtle means it is very subtle. It is very difficult to identify. Okay, so what will the baby do in subtle seizures? There will be only sucking movements, like this. All these slow movements, like cycling movements, like a baby is cycling. So that is called a subtle seizure. Okay, tonic, clonic, and myoclonic. Myoclonic carries the worst prognosis. Myoclonic is worst prognosis. Most common is subtle. Okay. What is the most common cause? What is the most common cause of neonatal seizure? It is hypoxic ischemic encephalopathy. It's the most common cause. Hypoxic ischemic encephalopathy. Okay. Now, what are the other causes? What are the other causes? Infections. What infections? Sepsis or meningitis caused by group B streptococci. Group B streptococci. Okay. Next, listeria. All these are some of the causes of meningitis in neonates. What are the other metabolic causes? Metabolic causes. What are the other metabolic causes? Other metabolic causes include hypoglycemia, hypocalcemia, hypomagnesemia. Okay. Hypoglycemia, hypocalcemia, hypomagnesemia are other metabolic or electrolyte causes. Okay. Other causes like inborn errors of metabolism also can cause neonatal seizures. So pyridoxine deficiency can cause seizures. It can also result in intrauterine seizure, where the treatment is you give pyridoxine to the mother. What is fifth day seizure? What is fifth day seizure? Benign neonatal epilepsy is called as fifth day seizure. Benign neonatal epilepsy is called as fifth day seizure. Okay, so now let's go on to the next question. Neonatal resuscitation, which of the following is the most effective indicator of successful ventilatory effect? So you're giving successful ventilation. How do you know whether it's going properly? Which is the most important indicator? Is it color change, rise in heart rate, chest movement, or chest rise? The answer here is rise in heart rate. Okay. So you're giving positive pressure ventilation. When there's an increase in heart rate, you know that you're giving ventilation properly. Okay. Now coming to NRP. This is the latest NRP program, 8th edition of neonatal resuscitation program. So what are the things we do in NRP? After the birth of the baby, you ask 3 questions. What are the 3 questions? Whether it's a term gestation or not, term or preterm. Whether the tone of the baby is good or not. The third thing is whether the baby is taking breath or not. Okay, so these are the 3 questions you ask. So suppose if all these questions, the answer is S, then what you do, you go to routine care. If it is no means you will do the next step. Okay. If everything is okay, baby is calm, baby is having good tone, breathing, crying normally, you will keep the baby with the mother, wipe everything, do everything, give the mother for breastfeeding. Okay. You don't have to do any resuscitation there. Suppose the baby is not dumb, the baby's tone is not good, it is limp, or if the baby is not crying or taking breath, if any one question answers no, then you have to go to the next step. What is the next step? You warm the baby, dry the baby, stimulate the baby and suction. Warm, dry, stimulate and then suction. After suctioning, you see if the heart rate is less than 100, if the baby is not taking breath, and then the next thing you do is you start giving positive pressure ventilation. So using what? We've already discussed positive pressure ventilation using bag and mask or TP's resuscitator. Okay, these are things that is used to give positive pressure ventilation. So after giving positive pressure ventilation, what you will do? You will look for increase in heart rate. If there is no increase in heart rate, the next thing you're going to do is some ventilatory corrective measures. So after positive pressure ventilation for 15 seconds, you give positive pressure ventilation for 15 seconds. Okay, when heart rate is less than 100 beats per minute, you are starting this positive pressure ventilation. You're giving this positive pressure ventilation for 15 seconds and then assessing the baby. If there is no increase in heart rate, you will do something called as corrective measures. What are the corrective measures? It is MR SOPA. The mnemonic is MR SOPA. M is mask. Okay. So you just position the mask properly and then you reposition the child. Okay. Next, S is for you suction and clear the secretions. O for open mouth. You open the mouth and start giving ventilation. P for increasing the pressure of ventilation. Positive pressure ventilation. A is alternate airway. If all this MR SOPA is not going to help, then you will go for alternate airway like laryngeal mask airway or endotracheal intubation. Okay. So after doing MR SOPA, again 15 seconds, you do MR SOPA and continue ventilation. After this, what you're going to see? You're going to see whether the heart rate has increased or not. If the heart rate is not increased, then you will go for endotracheal intubation or laryngeal mask airway. Okay. Now, if any point of time, if the heart rate is less than 60, if the heart rate is less than 60 per minute, it is an indication for starting chest compression. Okay. So you will start chest compression. So what is the ratio? 3:1. So 3:1 is the ratio. So 3 compressions, 1 breath. 1 and 2 and 3 and squeeze. 1 and 2 and 3 and squeeze. That is how you go. 3:1 or 90:30 in 1 minute. How much? 90:30. Sorry. So how many events in 1 minute? Total of 120 events in 1 minute. 90 compressions, 30 breaths. So this is the rate in chest compression is to breaths. Okay, so after doing chest compression and continuing with breaths, even if the heart rate does not improve, you will go for drugs like epinephrine. Okay, this is where you complete your neonatal resuscitation. These are the steps of NRP. So clear with the steps of NRP? Now, next question. A term baby born through meconium-stained amniotic fluid. Meconium-stained amniotic fluid did not cry at birth. Initial steps of resuscitation was done and heart rate was less than 100 beats per minute. What is the next step of management according to NRP? Is it tracheal suctioning, endotracheal intubation, positive pressure ventilation, or chest compression? So normally, after doing the initial steps, if the heart rate is less than 100, what do? You start positive pressure ventilation. So what is the case in meconium-stained amniotic fluid? What we should do? Do not get confused. Even if it is meconium-stained amniotic fluid, the steps are same. You are going to continue what? Positive pressure ventilation. According to the previous guidelines, it was totally different. Now, the present guidance says you are not going to deviate if it is a meconium-stained amniotic fluid. Clear? Just remember this. So, for a meconium-stained amniotic fluid, you will divide the baby into 2 types. One is vigorous and non-vigorous. What do you mean by vigorous? Vigorous means, so initially you deliver the baby. You see, the fluid is meconium stained, but the baby is active, moving all its limbs, breathing properly, crying. So baby is active, but the meconium is there in the amniotic fluid. Now what to do? Vigorous baby, you don't have to do anything. You will continue with the routine steps where along the side of the mother, as I told you here in NRP. If it is yes to all the questions, what you do? Stay with the mother for the initial steps. So you're not taking the baby to the warmer. You're staying with the mother for the initial steps. So you do the initial steps and give it to the mother. So you will shift the baby mother side if it's a vigorous. What do you mean by non-vigorous? Non-vigorous means the baby is amniotic fluid is meconium stained, but after delivery, the baby is not crying. The baby's tone is not good. Now, what to do? You will take the baby to the warmer. Okay. You will take the baby to the warmer and then you will do the initial steps. What are the initial steps? This dry, stimulate, suctioning. This you will do. Dry, stimulate, and suctioning. Oral and mouth suctioning and nose suctioning you will do. And then if the heart rate is again less than 100 beats per minute, like in this scenario where after initial steps, the baby's heart rate is still less than 100 beats per minute, you will do positive pressure ventilation. Clear? Previous guideline was to tracheal suctioning and tracheal intubation directly without doing bag and mask. Previously, bag and mask was contraindicated, but it is no more. According to 8th edition, you can continue with the routine steps. There is no deviation for meconium stain. So you will not do this routine tracheal suctioning, endotracheal intubation immediately. You will go on with the usual steps of resuscitation. Clear? Okay, fine. We'll go on to the next question. True statement regarding the image shown. So what is this image? What is this image? Anyone, please? What is this image? This image is this is nothing but kangaroo mother care, KMC. Kangaroo mother care. Yes, kangaroo mother care. Just like this kangaroo, it keeps his babies. They are marsupials. They keep the babies in the pouch. Likewise, we are doing something called as kangaroo mother care. What are we doing here? Can you see here? The mother and the baby are in skin-to-skin contact. So the main practical thing here is skin-to-skin contact. Okay. So what is true regarding KMC, kangaroo mother care? A, not recommended for babies on oxygen therapy. No, you can give for babies who are on oxygen therapy also. So this is the wrong statement. Duration should not be more than 12 hours per day. No, there is no specific duration. You can give as maximum as possible. Even 24 hours per day, the baby can be put on KMC. Okay, except for feeding or some purpose. Even feeding, even with KMC, you can breastfeed the baby. Okay, so this is also a wrong statement. Key features include early initiation, breastfeeding, early discharge. Yes, it is true. The three components of KMC is early initiation of KMC, continuing breastfeeding, and early discharge. Okay. The last thing, increases risk of apnea in preterms. Is it so? No. So it will prevent apnea in preterm. Okay. So what is this KMC? KMC is skin to skin contact. You remove all the baby's clothes except for the gloves and the cap, and then you keep the baby. You place the baby's abdomen over the mother's chest in between the breast. That is how you place the baby, and then you bind the mother and the baby together. That is KMC. So in KMC, it is mainly initiated for low birth weight and preterm babies. So what is the advantages of KMC? You provide warmth. Yes. Low birth weight and preterm babies, they are more at risk of hypothermia. So this KMC is going to prevent hypothermia. It is going to provide warmth. And what? The baby is just near the breast of the baby. So it is going to promote breastfeeding. Then, when the baby is with the mother, the risk of infections from other sources is also minimal. So it will reduce infections. And the most important thing is prevent apnea. How? These preterm babies, no, their respiratory center is still immature. So their risk of apnea. What is apnea? There is more period of absence of breath. They will not take breath for more than 20 seconds. Then you called as absence of respiration more than 20 seconds is called as apnea. So this apnea is due to the immaturity of the brain. So what happens when these preterm infants are put on the mother's abdomen or the mother's chest, the mother is going to breathe. So when the baby goes for apnea, mother's respiration, mother's abdominal respiration and chest respiration is going to stimulate the baby to take breath. So it will prevent apnea. It is not the risk of apnea. So it will prevent apnea. So these are the advantages of KMC. Okay, when will you say, what is the criteria to discontinue a KMC? So when will you say, okay, this is enough? So when to discontinue KMC? When the baby is more than 37 weeks or the baby's weight is more than 2.5 kg, you can stop KMC. More than 37 weeks, more than 2.5 kg, you can stop KMC. So this is about KMC. Next question. Which among the following is the preferred method of initiation of feeding is a 30-weeker born of normal vaginal delivery? What is the answer here? Is it IV fluids, orogastric tube feeding, palatal feeding, or dry breastfeeding? So feeding of low birth weight infants, feeding of preterm infants is an important question. So you will divide them into less than 28 weeks, 28 to 31 weeks, 32 to 34 weeks, more than 34 weeks. We will divide them into 4 categories. Okay. So in this first, less than 28 weeks, you will give IV fluids. Okay. For 28 to 31 weeks, you will give 28 to 31 gives, you will give feed. You can give breastfeeding through orogastric or nasogastric tube. You put a orogastric tube or nasogastric tube and you give feeds. 32 to 34 weeks, you can give palatal feeding through palatal. More than 34 weeks, you can give direct breastfeeding because their suck and swallow coordination would be better. So direct breastfeeding for more than 34 weeks. Okay. So the answer here is B, orogastric tube feeding for 30 weeks. So can you see what is this in the image? You would have seen this. This is called as a palatal. So this is called as a palatal. Okay. Fine. Going to the next question. Identify the false statement regarding this equipment. What is this equipment? Please tell me, what is this equipment? Some blue light is coming. What is this? This is called as phototherapy. You would have seen this equipment in the NICU. All those who have gone to NICU postings, you would have seen this equipment. This is called as phototherapy. So what is the use of phototherapy? Where do you use phototherapy in newborn? Phototherapy, where do you use? For neonatal hyperbilirubinemia. Neonatal hyperbilirubinemia or neonatal jaundice. Okay, fine. So now we are going to identify the false statement. We are going to identify which statement is wrong. Wavelength of light uses 460 to 490 nanometer. Yes, it is true. Photoisomerization converts bilirubin to lumirubin. Bilirubin is converted to lumirubin. That part is right. But is it being converted by photoisomerization? No. So what is that is going to convert? It is called as structural isomerization. Structural isomerization is the major mechanism of decrease in bilirubin. True. Maximum surface of the body should be exposed with eyes and genitals covered. True. So coming to phototherapy, what we are using this blue light. Okay, blue light phototherapy, LED. The thing we are using now is LED light phototherapy. Previously, we used CFL lights and all. Now we are using LED lights. Okay, so it is 460 to 490 nanometer. That is very important that you should know. The distance between the baby and the phototherapy unit should be at least 35 to 40 centimeters should be the distance between the baby and the phototherapy unit. Okay, so it has three mechanisms. This phototherapy, no, it acts by three mechanisms. The first important mechanism is structural isomerization. Structural isomerization. That is the major mechanism in reduction of bilirubin. So here what happens, this bilirubin is converted to lumirubin. In structural isomerization, bilirubin is converted to lumirubin. Okay. Next, second thing is photoisomerization. The second mechanism is photoisomerization. Here what is happening? The Z isomers are converted to E isomers. Okay. The third thing is photooxidation. This is a very minor part. What are the adverse effects? What are the adverse effects of phototherapy? Adverse effects of phototherapy, sometimes skin rashes, sometimes dehydration because more surface is being exposed. And you have something called as bronze baby syndrome. What is bronze baby syndrome? There is discoloration of the baby's skin. That is called as bronze baby syndrome. Where do you see? Suppose you're using this phototherapy for unconjugated jaundice is normally we use. Suppose we're using it for conjugated jaundice. For conjugated hyperbilirubinemia, if you use this phototherapy, you can get bronze baby syndrome. So you have to use it only for unconjugated hyperbilirubinemia. Clear with this? Okay, we'll move on to the next question. All of the following cyanotic heart diseases are characterized by reduced pulmonary blood flow except. So, cyanotic heart diseases with reduced pulmonary blood flow. Tricuspid atresia, tetralogy of Fallot, Epstein anomaly, TAPVC. What is the answer here? What is the answer? Any idea? Okay, cyanotic heart disease. How will you classify cyanotic heart diseases? Increase pulmonary blood flow and decrease pulmonary blood flow based on how much pulmonary blood is going. Okay, now take this heart. So whenever you want to study something in congenital heart disease, you draw a box heart. So what is this box heart? This is the right atrium, right ventricle. In between you have the tricuspid valve. Okay, so right atrium, what comes into right atrium? Vena cava, SVC and IVC. So from right atrium to right ventricle through the tricuspid valve. From the right ventricle, it goes to pulmonary artery, where it goes to the lungs. Okay, from the lungs, what is happening? Blood is going to the left atrium through what? Pulmonary veins. Okay, from the left atrium to the left ventricle to the mitral valve. From the left ventricle, blood goes to aorta, to the rest of the body. So this is your circulation. You know the systemic circulation. So pulmonary artery, from the pulmonary artery, blood goes to lungs. From the lungs, blood goes to the pulmonary veins to the heart. So this is what is happening, right? So pulmonary blood flow, they mean about this blood flow. Okay. So based on the quantity, how much blood is going to the lungs, only we are classifying the cyanotic heart disease into increased pulmonary blood flow and decreased pulmonary blood flow. Suppose there is some problem in this heart. Okay. So when there will be problem in the right side of the heart, suppose there is some stenosis, there is some problem with the right side of the heart, the pulmonary blood flow will reduce. If this is affected, means what is happening to the pulmonary blood flow? It will reduce. So what are the conditions where pulmonary blood flow can problem with this right side valve? What is that valve? Tricuspid atresia. So what will happen? Blood flow is reduced. So decrease pulmonary blood flow. First thing, tricuspid atresia. What about this? Something to do with this pulmonary wall, pulmonary stenosis or pulmonary atresia. Which condition you can have this pulmonary stenosis, atresia and all? TOF. So tetralogy of Fallot is one condition. And one more thing, Epstein anomaly. What is Epstein anomaly? Epstein anomaly is atrialization of the right ventricle. What happens? There is displacement of your tricuspid valve downwards. So what happens? Part of the ventricle also belongs to the right atrium. So there is atrialization of the right ventricle. So in Epstein anomaly also, right side blood flow, the pulmonary blood flow is reduced. So these three conditions are reduced pulmonary blood flow. When will you get increased pulmonary blood flow? Whenever more flow is coming to the right side, right? More flow is coming to the right side means you will have increased pulmonary blood flow. So one is TGA, transposition of great arteries. What happens in TGA? Aorta comes from the right ventricle, pulmonary artery comes from the left ventricle. So they are interposed. So TGA, increased pulmonary blood flow. The next one is truncus arteriosus. What is truncus arteriosus? The ventricles, so they empty into a common pathway from which the pulmonary vein and the aorta emerges. So you have a common pathway which both the ventricles entries. So that is truncus arteriosus. The third thing is TAPVC. What is TAPVC? Total anomalous pulmonary venous connection is called as TAPVC. These three conditions are increased pulmonary blood flow. So what is the answer to this question? All of the following have reduced pulmonary blood flow except. So they are asking which one has increased pulmonary blood flow. So the answer here is TAPVC. TAPVC is the answer. Okay, clear with this? Now we'll move on to the next question. A 10-year-old child presents with rheumatic fever followed by established heart disease. What is the duration of penicillin prophylaxis? So in rheumatic fever, prophylaxis is important. Prophylaxis is what? Secondary prevention. What is primary prevention? Primary prevention of rheumatic fever is sore throat or streptococcal infection is happening. And then there you prevent the occurrence of rheumatic fever. Okay. Identification of streptococcal infection and preventing the occurrence of rheumatic fever is called as primary prevention. But secondary prevention means already rheumatic fever has occurred. Now you are preventing the recurrence, that second episode or third episode of rheumatic fever. That is called as secondary prevention of prophylaxis. What are the drugs that you can give? One is benzathine penicillin. The first drug is benzathine penicillin. It is an intramuscular injection you give once in 3 weeks. Once in 3 weeks, intramuscular injection. So what is the dose? Less than 30 kg, you give 0.6 million units. 0.6 million. More than or equal to 30 kg, you give 1.2 million. Okay. 0.6 million, 1.2 million. This is the dose. Suppose injection is not possible, means the second thing you can give is oral penicillin. Penicillin V. Oral penicillin V. 250 milligram BD. The third thing, if they are allergic to penicillin, means you can give oral erythromycin. Oral erythromycin, 250 milligram BD. Okay, these are the drugs that you can give for prophylaxis. Now coming to the duration of prophylaxis. Duration of prophylaxis depends upon the rheumatic fever effect. Okay, suppose the child does not have carditis, no carditis. Okay, then you give prophylaxis for 5 years, till 5 years. I mean, extra 5 years after the rheumatic fever, or till 18 years of age, till the child becomes 18 years of age. Okay. Second thing, suppose there is mild carditis, mild to moderate carditis, like mild regurgitation and all. Then how much you give? You can give for 10 years or up to 25 years of age. 25 years of age. Okay. Now, if it is an established rheumatic heart disease, like your mitral stenosis, aortic stenosis, this established heart disease, valve involvement is there, or surgery has been done for the valves. Okay, surgery has been done for the valves. Here you give lifelong prophylaxis. You will give lifelong prophylaxis. So no carditis, 5 years or 18 years of age, whichever is longer. Mild carditis, 10 years or 25 years of age. Established heart disease or following valve surgery, lifelong prophylaxis. So what is the answer here? Here they are telling established heart disease. So you have to give for lifelong. So you will give lifelong penicillin prophylaxis. This is about rheumatic fever prophylaxis. Now, the next question. Same saturation in all cardiac chamber is seen in which disorder? They're telling that the saturation, if you take the right side as well as the left side of the heart, it is the same. So where do you get? You all know this right side is carrying deoxygenated blood. Left side is carrying oxygenated blood. So there should be some difference, right? So when will you get both the chambers as equal? Both the sides are equal. So it means that there is total mixing of blood, right? There is total mixing of blood. How? So this condition is called, seen in TAPVC, total anomalous pulmonary venous connection. What do you mean by TAPVC? Normally, where does pulmonary vein empty? Pulmonary vein normally into the left atrium. So from the lungs, pulmonary veins come and empty into the left atrium, right? This is what is happening. But in total anomalous pulmonary venous connection, what happens? They do not empty into the left atrium. They will go and empty into the right side of the heart. Okay, they will make a connection and then they will go and empty to the right side of the heart. Okay, so right side of the heart, you all know you have this SVC and IVC carrying the deoxygenated blood. Okay, right side you have the SVC and IVC. Okay. Right. So now what happens? Here in TAPVC, you have three types. One is the supracardiac, second one is the cardiac, and the third one is the infracardiac. Based on the place of emptying, these types are there. So supracardiac means what happens? All the pulmonary veins, they join together and empty into the SVC. Empties into right SVC, where above the cardiac. It's not directly emptying into the heart. It is above the heart. So it is supracardiac. In the SVC, it will come and join. That is called as supracardiac. Okay. The next cardiac is directly into the right atrium. Directly into the right atrium, it will come and empty. Infracardiac is it will empty into the portal vein. It will empty into the portal vein. So what is happening? Here, if you see, this left side of the heart is not receiving blood. Only right side is receiving both the deoxygenated blood as well as the oxygenated blood. So both these are emptied to the right side. So what should happen? There should be some blood going to the left side. How will the blood go to the left side? The blood will go to the left side through this patent foramen ovale. Through the foramen ovale, this blood goes to the left side and then comes like this. So can you see, as there is mixing of blood in the right atrium, both the oxygenated and deoxygenated is mixed in the right atrium before distributed, you will have equal saturation in all the four chambers in TAPVC. Clear? So after mixing, the blood is going to the left atrium. That is why all four chambers you have equal saturation in TAPVC. Okay. So some important points about TAPVC. X-ray appearance of TAPVC is important. Figure of 8 or snowman appearance. Figure of 8 or snowman appearance is seen in supracardiac. Okay, it is not just SVC. It is supracardiac TAPVC. Okay, in infracardiac TAPVC, you will get a picture called as ground glass appearance, similar to your RDS, hyaline membrane disease. So ground glass appearance in infracardiac TAPVC. Okay, this point is important. So clear about TAPVC, all chambers will have equal saturation. Okay. Now going to the next question. Which among the following heart disease is characterized by cyanosis at birth large A waves in JVP, left ventricular hypertrophy, left axis deviation. Transposition of gate arteries, TAPVC, tricuspid atresia, TOF. What is the answer? Answer is tricuspid atresia. Do not forget, when you get a clue as left axis deviation in a cyanotic congenital heart disease, close your eyes and answer tricuspid atresia. I'll tell you why. Again, we'll go to our box heart. Okay. So, what is happening in tricuspid atresia? What is happening in tricuspid atresia? This valve is not there. Tricuspid valve is not there. So, what happens? Blood from the right side cannot go into the right ventricle. So, what will happen? The blood will pass through the foramen ovale and go to the left side of the heart. So, goes to the left atrium, left ventricle, and then goes to the aorta. Now, what happens here? This chamber is small. It becomes hypoplastic because blood is not coming through the right side. So, what happens? There will be a ventricular septal defect. Through the ventricular septal defect, this blood will enter and go here. But then there will be only small amount of blood going through this shunt. Majority of the blood goes through the aorta to the left side. So, what is happening? There is left ventricular hypertrophy and there is left axis deviation. Left ventricular hypertrophy, left axis deviation because of tricuspid atresia. So this clue, left axis deviation, means you close your eyes and answer tricuspid atresia in case of cyanotic heart diseases. Okay, I'm telling about cyanotic heart diseases. Answer is tricuspid atresia. Okay. Now, next question. What is the recommended age group for inhalation device shown? What is this device? What is this device? You can see a mask with a spacer and a meter dose inhaler. What is this? This is a face mask. What is this? This is a spacer. What is this? This is a meter dose inhaler. So this meter dose inhaler will have the drug. Okay, it will meter dose in the sense only particular amount of drug will be delivered in every puff. So this spacer and then face mask is used for delivery. So you have inhalation devices through which drugs are delivered in case of asthma. So this face mask, spacer, MDI is recommended for which age group? Less than 4 years, for small children, because they cannot directly take in the inhalers. For these children, you give face mask, spacer and MDI. What are the other devices? What is this? Here you can see spacer and MDI without a mask. Spacer plus